if he's got time, Dr. Tiwari, we can invite him for our annual meeting, which is going to happen at Patna.
Definitely.
Yes, yes. So Dr. Sunil Jha is very much a product of Patna Medical College, and he has done his post-graduation from Darbhanga Medical College. After that, he switched over to England, done his MRCP, and then he moved to America. I think 2019, 2022, and 92, 93, he moved to USA, where he did his fellowship in cardiology, electrophysiology, and now he is almost like he's professor of electrophysiology in University of Tennessee, which is a great prestige, because a guy who is after money and totally dedicated to education, medical education. And for the last, I don't know, maybe many decades, he's coming to Patna, and we are having the privilege of listening to him. And last 2 years, I have become more active in inviting him and trying to extract whatever he has. This gentleman is thoroughly uh, into the cardiology business and electrophysiology business. And last year, uh, I was invited by him. Rather, I made myself available for his lab. So where I was in his lab, watching him doing the procedures, which he has been doing for many years. But that was a special occasion on 19th of March last year, when he was doing a pulse field ablation. This is a new modality of atrial fibrillation ablation, which is not there still in India. So this pulse field ablation is a new modality all over the world. This is being taken up in Western countries, America. I think there are nearly 50 centers, maybe Dr. Sunil Jha will tell you. And one of the center is his hospital at Memphis. And this procedure gives you results instantaneously in atrial fibrillation ablation. Uh, Two types of things, what she will describe briefly. But we are today concerned about the basic teaching in bradyarrhythmia, which is very, very common. And often, we confuse that which patient should be given pacemaker or not. So, uh, without wasting time, I would request Dr. Sunil Kumar Jha to uh, bless the occasion with his talk on bradycardia. And we have two moderators. Are they there? Dr. Pawan. Dr. Pawan, are you there? Dr. Anupam, are you there? Sunil, Anand, can you speak to these two guys? Anupam Bhammani from AIMS Patna, and Pawan Kumar Singh from Medanta Patna. The two guys, I requested them to be our moderator today. So आनंद एक बार उनको कॉल कर ले.
Okay, in the meantime, Dr. Ajay, send the biodata and email address of Dr. Jha.
Yes,
with topic. I will.
Yes, sir. Yes, sir. That doctor, I'll request him to select a topic, and his availability, that is a problem.
Yeah.
His availability and conferences would be in January, is not it? Patna conference.
29th is CME there.
Yes.
29th January.
Yes. So maybe we can. हाँ, आनंद.
जी सर, फोन नहीं पिक कर रहे हो.
कौन?
वहाँ अनुपम मैम.
अच्छा, अनुपम मैम फोन नहीं पिकअप कर रही हैं. एक मैं करता हूँ उनको. पवन को पहले करता हूँ, पवन को.
Good morning, Kamlesh ji.
Morning, sir. Morning, morning.
Morning.
You
Where are
passed
you?
MD from Darbhanga.
I was in Patna for MBBS and then went to Darbhanga for MD.
When was that?
Huh?
I think batch
Huh?
was 83, 85.
Good evening. आ जाइए.
83, 85. I was just a year junior to Ajay ji in Patna Medical College.
Let's see.
रास्ते से कर लीजिए ना ज्वाइन.
We did
रास्ते से ज्वाइन कर लीजिए.
residency
रास्ते से ही ज्वाइन कर लीजिए.
with Dr. Sivnarayan Singh together. So it's a
रास्ते में ही ज्वाइन कर लीजिए.
we were close to each
हाँ, लिंक
other.
भेजा है मैंने. लिंक भेजा है मैंने आपको. मोबाइल से ज्वाइन कर लीजिए, कोई दिक्कत नहीं.
Dr. A.K. Thakur,
Yeah.
my wife's uncle, so he was my mentor. So I've been attached to that. After he has left, Ajay ji has been very academically active. So that's a boon for that city and that for state. क्या शुरू किया जाए क्या बस क्या
एक
वेट
मिनट.
करें
I'm talking to Anupam and just Pawan is actually coming back from Jahanabad.
एमडी के लोग हैं
हाँ
कहिएगा
हाँ
उनको वो
हाँ.
अनम्यूट करने जस्ट ए हाउस कीपिंग ताकि डिस्टरबेंस नहीं हो लेकिन क्वेश्चन के समय में दे कैन पुट देयर पिक्चर ऑन
Please go ahead with Dr. Sunil, please.
क्या शुरू करें नहीं वेट करें many of them were under impression that we will start 6 o'clock their time.
Yes, sir. It is better to start.
क्या start करें अजय जी? Okay.
Please go ahead. Please go ahead.
Good morning, everyone. I'm delighted to be part of this team and to be invited. I'm honored to be invited for this talk. Thank you, Ajay ji, for kind introduction. Dr. Tiwari and all other members of this organizing committee. I'm really indebted that you guys are doing so much to improvise and enrich the knowledge of the coming generations. I always say knowledge is good, but wisdom is even better. And if you contribute your knowledge, that's a noble mission that you all are doing. It's very humbling, we are indebted to your effort, what you're doing for enriching the coming up community of the cardiology and the medical team in the state. And Dr. Sinha asked me to pick up a simple topic, so I thought evaluation of bradycardia will be a good choice. Well, I will not be teaching you what is right bundle and the left bundle branch block. It will be a little bit of higher level so that everybody can learn some new things. This is my favorite topic. Currently, I'm an associate professor of medicine and the director of clinical cardiac electrophysiology at University of Tennessee. We run the fellowship here. So let's start. This is the summary of my talk. I will start the anatomy of the cardiac conduction system, relationship between the intracardiac conduction and the EKG. Then we switch over to proper bradyarrhythmia. And if time allows, we'll say a few words about the pacemakers. So I will keep you engaged for the next 50 minutes. And then we'll keep for the question and answers the last 10 minutes. If people can take the picture off, that will be helpful for me, and unmute it. We can talk later. The conduction system of the heart, this is the simplified way. We have sinoatrial node, which is a powerhouse of the heart. This is an subepicardial structure. It is located between the right atrial appendage and the superior vena cava, where superior vena cava joins the right atrium, and the right atrial appendage is in the anterior part of the right atrium. Between these two, good morning, Dr. Anupam. Dr. Ambani, good morning. Welcome. So I just started, I was talking about the conduction system. So sinoatrial node is the subepicardial structure lying between the right atrial appendage and the superior vena cava junction to the right atrium, okay? And then you have AV node. Between sinoatrial node and AV node, there are some internodal tract. Internodal tract could be anterior tract, middle tract, and the posterior tract. Then the right atrium is connected to the left atrium by a bundle of nerve, which is called Bachmann's bundle. Bachmann's bundle is lying in the anterior and superior part of the septum. So if I am the left atrium, close to the roof of the left atrium, and putting my catheter anteriorly on the septum, that's the area where the Bachmann's bundle is. That connects the right atrium to the left atrium. AV node continues in bundle of His. You can see the bundle of His is physiologically lower structure than the AV node, but anatomically it is higher. So if I have to put the catheter, I will put the catheter higher for the His bundle. And that divides into a right bundle branch and the left bundle branch. Left bundle branch divides into two fascicles, left anterior fascicles and the left posterior fascicles, which are not visible here. So, and then the Purkinje fibers that goes into the myocardium of the ventricle. So that's the electrical system of the heart. So let me just quickly tell you the sinus node, that's the natural pacemaker. The rate of the sinus node is 60 to 100 beats per minute at rest. And then AV node receives impulse from the sinoatrial node, delivers impulse to the His Purkinje system. And if sinus node shuts down, AV node can fire, but it cannot fire more than 40 to 60 beats per minute if sinoatrial node fails. And then comes the bundle of His. It begins conduction to the ventricle. And AV junctional tissue starts from here. The rate in the upper part, the proximal part of the His will be 40 to 60 beats per minute. But as it goes down, the Purkinje network, it's the bundle branches that goes into Purkinje fibers, moves the impulse through the ventricles for contraction. But escape rhythm of the Purkinje fibers cannot be more than 20 to 40 beats per minute. The reason I've been telling all these rates are the lower the block, the escape rhythm will be slower. If you block in the His bundle, what escapes? The bundle branches escapes. If you block further down in the His bundle, what escapes? The Purkinje fibers escapes, but they cannot take the heart rate more than 40 beats per minute. So lower the block, slower the escape rate. Okay. What is the relationship between the intracardiac conduction in EKG? I will be very quick. The sinus node goes into the atrium, and that gives you the P wave. And then it goes to the AV node. Conduction in the AV node, the PR interval is basically, if I ask the fellow what's the PR interval, the common answer is AV node conduction. Actually, PR interval is the time for the electrical current coming from the sinus node to the ventricle. So the PR interval has different components. Components in the beginning, I will show you the intracardiac, that's the conduction through the AV node. Then comes the conduction through the His bundle area. And then comes the conduction through the Purkinje fibers, then the QRS starts. Okay. And then the ventricle is depolarized, that gives you QRS complexes. And then, if you remember the action potential, there is a zero. Well, I should have shown the action potential so that later. The zero phase, the phase 1 and phase 2 is the plateau phase when the calcium goes inside the myocardium, and that gives you the ST segment. Okay. And then the phase 3 of the action potential gives you the T-wave repolarizations. So you can see the repolarization phase of the heart is much longer than the depolarization phase, right? So this is basically the same thing, the summary of that, how the atrium is depolarized, what does PR interval consist of, what is QRS duration, ST segment, and the T wave. Okay, in the heart, when we study, okay, there are four catheters. Four catheters study. Just let me move this. A standard 3 catheters plus coronary sinus catheter. So we put one catheter in the high right atrium, one catheter goes in the coronary sinus. It has multiple electrodes. One catheter will be in the right ventricle, and one catheter will be at the His bundle. So this is how we study the conduction system of the heart. Okay, when we record these conductions, electrical currents from inside the heart, they are called electrogram. When you record the electrical phenomena inside the heart through the surface of the body, that's called EKG. The intracardiac is always called electrogram. So here I am just giving you quick idea. These are the surface EKG. This is the high right atrial recording, and then the His bundle records partly A, then the sharp S, that with the His spike, and then the V comes. Coronary sinus runs between the A and V. It records both atrial and the V, A and V signal, A and V signal, A and V signal. As we go distally, it is close to left ventricle. So the ventricular signal starts getting bigger. When it is proximally, then it is closer to the atrium. The atrial signals they are bigger. So when you measure between high right atrium to the next high right atrial cycle, that's called AA interval. That's a measure of atrial rate, also known as atrial cycle length. When you measure the A to beginning of the A on the His channel to the beginning of H, that gives you AH interval. That's a measure of AV nodal conduction time. When you measure the beginning of the His to whatever comes first, if QRS comes first or the intracardiac beginning of that, that's the HV interval. That is a measure of His-Purkinje conduction time. So this is my case. We are measuring A to H. That's usually around, that's normal, around 1 to 10 milliseconds, up to 120 milliseconds is normal. HV interval, usually it is between 30 to 60 milliseconds. 70 milliseconds will be little prolonged. And then, so that's how in the EP lab, we look for the conduction system, okay? The rhythm disorders, let me just talk, coming to bradyarrhythmias. I always say the EP is very simple. You have to deal with tachycardia or bradycardia, right? So let's classify bradycardias. The bradycardias could be secondary to impulse formation disorders, okay? Or it could be secondary to impulse conduction disorders, right? For example, impulse formation disorder, where the impulse is not being formed, sinus bradycardia. Sinus node is slow. Okay, that's the sinus bradycardia. Then suddenly the sinus race, the sinus node may stop. That is called sinus arrest. For example, here you have PQRS, suddenly no P, and then the P wave comes. The failure of sinus node discharge, then absence of atrial depolarization. What is this? And then the other condition is called tachybrady syndrome, which I'll be defining clearly how to exactly call it tachybrady syndrome. Then suddenly. So in tachybrady syndrome is very loosely utilized by the cardiologist also. Tachybrady syndrome is very clearly should be defined in a way. The tachycardia could include atrial fibrillation, atrial flutter, or atrial tachycardia. When that tachycardia suddenly stops, there's a big pause. Sinus node takes a long time. It is a syndrome. So the patient has to have symptoms. They are feeling dizzy, they feel like faint. So tachycardia, it's not that patient has been running and they have sinus tachycardia and they sleep, they have bradycardia, and we are asked to put the pacemaker, it's tachybrady syndrome. No. Patient needs to have AFib or flutter or atrial tachycardia, and when they break, the sinus node takes long time, and during that long time, patient is symptomatic. That is tachybrady syndrome. This is my recording. This patient has some kind of atrial tachyarrhythmia, looks like maybe atrial fib, and suddenly the atrial fib breaks, and look at the sinus pause, and patient feels like a faint. That's tachybrady syndrome. Okay. Then impulse conduction disorder, it could be sinoatrial exit block. The block is between the sinus node and the atrial tissue, the sinus atrial exit block. Means sinus node is producing the current, but that current is not able to penetrate into the atrium. So it's a transient block of the impulse from the sinus node. It is identified by the PP interval relationship. Since sinus nodes keep firing, and one firing cannot conduct into the atrium, so the P to P relation, when it is a pause, is always mathematically related to the basic P to P interval. So suppose the rate is 60, sinus rate is 60, and one beat could not conduct, then the gap will be 120. The gap will be 2 times longer than the normal P2P interval. If 2 beats cannot go through, then the gap will be equal to 3 times the normal P2P interval. So there is always a mathematical relationship between the P2P pause and the normal P2P interval. That's sinoatrial exit block. In case of sinus arrest, because the sinus node stops working, there is no mathematical relationship between the paused P2P interval and the normal P2P interval. That's the difference between sinoatrial exit block and sinoatrial arrest. For example, this one, so sinus, this is the ladder diagram, sinus node comes to atrium, sinus node comes to atrium, but it takes a bit more time, here a bit more time, and then this one drops. This is called sinoatrial exit block type 1. So Morbus type 1 can happen at the sinoatrial junction also. I'm going to talk about this a bit later. This was the EKG given one of my colleagues, Sunil, what is this? And then when you go there, this was Morbus type 1 at the sinoatrial Wenckebach, which I'm going to define after I define the AV Wenckebach. The sinoatrial exit block, the second, the AV block. The AV block could be of different types, which I'm going to go over. So if I give the question, this says that which of the following is the most common mechanism of syncope in the sinus node dysfunction? So these are all the different manifestations of sinus node dysfunction. Patient can have sinus bradycardia at the resting sinus bradycardia, they have sinoatrial exit block causing sinus pause, or they're exercising, the sinus rate is not picking up, that's called chronotropic incompetence, or they have tachybrady syndrome. But if this question comes, the most common mechanism of syncope in sinus node dysfunction, all of them could be presentation of sinus node, but the tachybrady syndrome is the one most common to cause syncope. The tachybrady syndrome is the most important. The evaluation of the suspected sinus node dysfunction, actually we don't do the evaluation too much because it all depends. Our decision about pacemaker depends if the patient is symptomatic or not. So EKG monitoring, okay, the exercise test could be formal exercise test. You can put the patient on treadmill, or in my clinic, I tell the patients to exercise minimally 10 times, go up and down with the arms, and it is not going. That's the clinical electrophysiologic testing. The sinus node recovery time, we hardly measure it nowadays, and the sinoatrial conduction time, these are done in the EP lab, And then also there is something called intrinsic heart rate. We used to give beta blocker, we used to give parasympathetic drugs, and then after that we used to see what's the patient's heart rate. We don't do these things nowadays because our decision about the pacemaker depends on if the patient is symptomatic or not. Okay, so briefly, how do we do sinus node recovery time? You pace the atrium a little bit faster than the patient's own rate and come off the pacing. Here are pacing, and then see the last pacing spike to the return of the P wave. That's the measurement of sinus node recovery time. And there is something called corrected sinus node recovery time. You measure this one minus the normal sinus rate, normal sinus rate. That's the corrected sinus node recovery time. Sinus node recovery time up to 525 is normal. But I don't have to do this test to figure out if the patient needs a pacemaker or not. Okay, so what happens in this case? You give the impulse, that goes to the sinus node. You are pacing faster, go to sinus node, it resets the sinus node, and the sinus node then fire later, and that comes back to the atrium. So the distance between the A1 and A2, that will be the sinus node recovery time. Okay, and same thing, corrected sinus node recovery time. And it takes about, when you pace the atrium for a few seconds, it takes about 5 seconds, usually 4 to 6 beats for the normal beat to come back. That's called total recovery time. We don't have to know this. Okay, the first degree AV block is simple. PR interval is more than 200 milliseconds because of delayed conduction through the AV node. Okay, that's first degree AV block. The second degree AV block, I'm going to spend some time here. It's also known as Wenckebach block. That there is a progressive prolongation of the PR interval until there is a failure to conduct and a ventricular beat is dropped. So PR, 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 P, no R. So that is the Wenckebach phenomena. Many people don't know what is Mobis 1 and what is Wenckebach. So last night, I took a bit of historic perspective. Wenckebach was born, he was a Dutch, was born in Hague. He was at first a Dutch anatomist. So he wrote a paper long time ago, that there could be a progressive lengthening of the PR interval. Then there is a drop. There is a drop QRS there. I'm getting some difficulty here though. Okay, so Wenckebach is primarily remembered for his work in cardiology. Later, he was an anatomist first. Later, he became a cardiologist. He went to Austria, where finally he died. In 1899, he provided the description of irregular pulses due to partial blockage of the AV conduction, creating a progressive lengthening of the conduction time in the cardiac tissue. So that was Wenckebach. His paper somehow could not get that popularized until Mobis came. Mobis, he was born in Russia, in St. Petersburg, and then finally he came to Germany, and he described almost the similar thing. But that paper in 1905, not 1905, 1925, that get very popular, and that is called Mobis type 1 AV block. So it's the same thing, but the two different scientists. Wenckebach described a long time ago, but it didn't get popularized until Mobis came, and then he described Mobis type 1 AV block. So I just wanted to put you there. So this is how it looked in the conduction system in the lab. I'm pacing the A, the surface EKG, A, and then these are the His bundle recordings. A, H, V, A, H, V, A, H, V. This is 1-to-1 conduction. And then suddenly what happens? There's A, no H, means it is not going to the His bundle. It is blocking in the AV node. That's AV node Wenckebach. So A, no H, no V. If there is a then H, then no V. That means the block is infrahisian. Here, the block is in the AV node. That's AV node Wenckebach. Okay. Everybody should concentrate on this diagram. This is the typical laddered pattern of the AV Wenckebach. So here the atrial rate is 800 milliseconds, means P to P interval or A to A interval is 800 milliseconds. That gives you 60,000 divided by 800. That will be 75 beats per minute. Here, AV node conduction, AV node here, PR interval is 0.818. That means 180 milliseconds. Then the next one prolongs to 0.24 milliseconds. So 0.24 minus 0.18, and so 0.06, 0.8 plus 0.6, that will be the R2R interval. The next one is longer than 0.24, is 0.26, but the difference from the last one is shorter. So 0.26 minus 0.24 is 0.02 only. So 0.8 plus 0.02 is 0.82. The next one is longer. Absolute value is longer, but the difference from the last one is even less than the one before. Here it is 0.27, PR further prolongs, but 0.27 minus 0.26, that gives you 0.01. So RR interval is 0.81. So what's the meaning of that? There is decremental increase in the PR interval. That's the word we should. PR interval goes prolong, but the most prolongation happens in the first time. Second one would be less, so RR interval in case of Wenckebach gets shorter. Even the PR interval gets longer, but the PR interval prolongs, it increases in the decremental fashion. Okay, it's like having 4 suns. But the first sun, the second sun gap is longer. And the second sun and third sun is less, not 5 years, 3 years. The third sun and the fourth sun will be 2 years gap only. Okay, so even though you are younger, but the gap started getting shorter. So RR interval is shorter. It gets shortening of the RR interval in case of Wenckebach. And then there is a drop here, and then AV node recovers to the baseline 0.18. So that if you combine the P to P interval times 2 here, this gap is shorter than the 2 times normal P to P interval, because 0.18, here 0.27, that difference, because if it was 0.18, then the gap here, RR interval, will be equal to 2 times PP interval, but it was prolonged here and 0.18 here. The gap is 0.09. So if you see that, it's not 1.61, it is 1.51, because the gap here was longer. So the last P to P interval with the blocked QRS is less than 2 times of the normal P to P interval. So let me summarize. So in case of AV Wenckebach or Mobius type 1 block, there is a progressive PR prolongation, and then there is a dropped ventricular beat. Then RR interval shortens because of decremental increase in the PR interval. Then RR interval with the dropped QRS is less than 2 times P to P interval. And the shortest PR comes after the dropped QRS. So these are the different components I summarized. The same thing can happen at the sinoatrial junction also. So P wave to P wave, so P to conduction from sinoatrial node to the A gets longer, but longer, this difference is more than this difference. So the P to P interval gets short, and there is a drop P to P, there is a drop P wave. So here, if you measure P to P interval, then P to P interval, and there is a drop P. So that's sinoatrial Wenckebach. Sinoatrial Wenckebach. It can happen, but you can catch it if you think about it. So shortening of P to P interval, then there's a drop P. That's sinoatrial block. So second degree AV block, Mobius type 2. Okay, Mobius type 2. Very commonly, there is no PR prolongation. and then suddenly the drop QRS, that is not Mobius type 2. To call it Mobius type 2, you must have evidence of infrahesian conduction disorder. Right bundle branch block, left bundle branch block, left anterior fascicular block, and then P conducts to QRS, P conducts to QRS, and suddenly without PR prolongation, P is there, no QRS. Here, this patient has bundle branch block. You can see the PR interval is same here and here, and then P, there's no QRS, P, no QRS. PR interval is same as this one. That is called Mobius type 2. What is the implication? Because Mobius type 2, they have higher chance of going into complete AV block. That's why Mobius type 2 becomes a stronger indication of pacemaker rather than Mobius type 1. Mobius type 1 is not the indication of pacemaker implantation unless the patient is symptomatic. So this patient is mine. He came with syncope, you have right bundle branch block. We did not know the cause of syncope. We put the catheter in the heart. Look at this, AHV, AH, no V. There is an infrahesian block, AHV, and then AH, no V, infrahesian block. This patient needs pacemaker. That's why he was going to complete heart block. So we sometimes give, here what's happening, AH, no V, AHV, then AH, no V, AHV. So infrahesian 2-1 block. This patient definitely needs a pacemaker. And this is a spontaneous. I did not give any sodium channel block. So that's how we decide. This patient came with passing out, and the patient has PR interval normal, then the P wave, no QRS, PR interval normal, P wave, no QRS. It's hard to call it Mobius type 2 block because there is no definite evidence of infrahesian conduction disorder in this case. Okay, so in this case, but the patient was symptomatic. So what normally we do, ask the patient to do some exercise. You see the P to P interval goes faster, and then the block gets worse. Block gets worse. So this is a different patient, came in the left bundle branch block, and we did the conduction study. What is this? So this is a hiss, and then again hiss, then again hiss, two hisses. This is called intrahesian block. There is a conduction disorder in the hiss bundle itself. That's called intrahesian block. We wanted to further study this guy. So this is A, H, H, another H. So intrahesian block, A, H, another H block. So this patient had both evidence of intrahesian block as well as infrahesian block. So that definitely needs a pacemaker. So this question comes, I made this, during 2-1 AV block, a narrow QRS complex and a conducted PR interval of equal to or less than 160 milliseconds suggests that the level of block is AV node, intrahiss or infrahiss or fascicular. If the QRS complex is normal, PR interval is normal, then the block is intrahesian. So the block is intrahesian. So what is the meaning of that? AV conduction assessment, how do we do that? PR is prolonged and narrow QRS. The block is AV nodal. PR is normal, QRS is wide, infrahesian block. PR is normal, QRS is also narrow, that's intrahesian block. Okay, you don't put normally the pacemaker with the AV nodal block, but these two will need the pacemaker if the patient has come with some symptoms. So this is another question it comes. A form of second-degree AV block that is rarely or never seen is type 2 block in the infrahesian level or type 1 block in the AV node, type 2 block at the infrahesian, type 2 in the AV node, type 1 at the so there are many things. So type 2 AV block never happens at the AV node. So that is the answer. Type 2 in the AV node never happens. Type 1 or type 2 can happen in the infrahesian level, intrahesian level, but type 2 never happens at the AV node. So that should be the answer. So here, third degree block, easy, no impulse conduction from the atria to the ventricles. So depending on where is the block, the ventricular escape rate will vary depending on that. The ventricular rate is usually 37 beats per minute. So in this case, this is the third-degree block. Patient has evidence of infrahisian conduction block, and there is PR interval is not related to each other. PR interval is different. So P is going on its own rate, and the QRS is going on its own rate. That's the third-degree block. So then comes the bundle branch block. So I have mentioned about the exit block, first degree, second degree, and third degree in the bundle branch block, which I'm not going to, you all know about this one. The bundle branch block, I'm not going to say that. This is left bundle branch block, and this is right bundle branch block. I think this is quickly for those who are the higher level, but those, okay. There are two things important. One is called phase 3 block, and one is called phase 4 block. The phase 3 block, what you call Ashman's phenomena. In case of AFib, what happens? There's a long interval, and then there's a short interval, and there is a bundle branch block. This is long, short, because the block is in the phase 3 of the action potential. This is normally happens this is the normal physiologic phenomena. If there is some conduction disorder, then it could be phase 4 block. This is what happens. PR, normal QRS, PR, normal QRS, PR, normal QRS. Then look at the T wave here, T wave. There is a P wave here. There is a premature beat. And then after there is a pause. And after the pause, there is a wide QRS. There is a wide QRS. Because what happens when the rate is slow, somehow the membrane potential of the His-Purkinje system, that also gets disturbed, and then the conduction is slow. This is called phase 4 block, because the block happens in the phase 4 of the action potential. So this is a bit higher level, but I enjoy it, so I just wanted to share with you. Usually phase 4 block happens when there is some baseline infrahisian conduction disorder. But this long short is phase 3 block, short, long. Short means here to here is short, and then the long interval, and then the block happens. Here, R to R is long, and then the next one is short, and then you have a block here. That's Ashman's phenomena. That's a physiological phenomena. So that's being said, that's what I was telling you, different phases of the action potential. Phase 3 block happens here, phase 3 block happens here, phase 4 block will happen here. These are different causes of bradycardia. I don't have time for that. It could be congenital heart disease, acquired heart disease, drug-induced, or something called neurocardiogenic phenomena. So that's. Do we have time? Yes. Few words about the pacemakers. I'm not going to go into the details, but few words. The pacemaker could be atrial pacing, ventricular pacing, or sequential AV pacing. Atrial pacing, the wire is in the atrium only. Ventricular pacing, the wire is in the ventricle. If it is sequential, that means the wire is in the A and the wire is in the V as well. This is the X-ray of the chest X-ray of the dual chamber pacemaker. Looks like you have atrial lead. This is the V lead. It's always good to look the X-ray in the lateral view, because the right ventricle is anterior. This is the spine. It has to go anteriorly. That's normal. Okay. If it goes this way, that means you are towards the left ventricle. Okay. So that is important to look at when you look at this one. The pacemaker mode. Normally you'll say that what is VVI, what is DDD pacemaker? To understand, predict, and the troubleshoot the pacemaker behavior, it is critical that someone understands the pacemaker timing and the pacemaker modes. The pacemaker mode defines, number one, if I say VVI, the first letter defines that which chamber is paced. The second letter defines which chamber is sensed. And the third letter defines if the patient, what is the response of sensing? If there is a normal QRS complex, it will inhibit the pacemaker, it will be VVI. If there is no QRS complex, then the patient fires. If there is a QRS complex, patient will not fire. That's the demand mode. So it defines the chambers that are paced and sensed. defines how the pacemaker will respond to the intrinsic events. And sometimes we put R at the end that defines if rate modulation is available in that pacemaker or not. So there's NBG, that's called NBG code, like a VVI, DDD. What is NBG? NASP, HR, Heart Rhythm Society in America used to be called NASP, North America Society of Pacing and Electrophysiology. And then British Pacing and Electrophysiology Group, NASP and BPEG, they both combined, then the word became NBG code. That came in 2002. Initially, it was defined 1983. Then with the complexity of the pacemaker, the new NBG code, they came. It could be VVI, rate response is on, VVIR would be DDD, that means you are pacing both the chambers, you put the R, then the rate response. And there's something called DDIR. If the upper chamber is too fast, pacemaker conduction inhibits, okay, to prevent the rapid heartbeat, and that's called DDIR, or it could be AAIR. Quickly, I'll tell you. So watch this video. So V-paced, 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 that's a VVI mode. Why it is VVI mode? But here V-paced, and the PVC comes. If the PVC comes in the VVI mode, it will inhibit the pacemaker, and then the timing will start from here, where it is senses. From here to here, the same distance. If it is 60 beats per minute, that means 1,000 milliseconds. 1,000 milliseconds here. Here, the sensing comes, it inhibits the pacemaker, and but again, the time cycle starts from here to here. That's a VVI mode. If you make it VOO, that means it results in the fixed rate pacing in the ventricle. Put the magnet over the pacemaker, it will result in this behavior. The application of magnet can be used to inhibit the oversensing during surgery, troubleshoot the pacemaker, or assess the device's battery status. So what happens here? V-paced, V-paced, V-paced. That this beat came, it did not inhibit the pacemaker. Did not inhibit the pacemaker. This is VOO pacing. Okay, so in DDD, that's a bit, okay, the DDD, it can pace both the chambers, it can sense both the chambers, and if there is no normal QRS, the pacemaker will get triggered. If there is a normal QRS present, pacemaker gets inhibited. So this is how it goes. So A-paced, V-paced, okay, this is AV sequential pacing. Sinus node is slow. That's why the atrium is pacing all the time. AV conduction is slow and no normal conduction comes. The AV delay expires and the V-pacing happens. V-pacing happens. So here, what happens? Sinus node is slow. That's why it is pacing all the time in the A. But AV conduction is normal. But that's why A-paced, V-sensed. A-paced, V-sensed. Here, sinus node is normal. So A-sense, but the AV conduction is slow. That's why no normal beat comes, the pacemaker fires. ASVP. If both of them are normal and happens intermittently sinus node dysfunction or intermittent AV conduction block, in that case, you will see ASVS. ASVS is sensing the A, pacing, sensing the V also. So there are 4 phases of the dual chamber pacing. The first one, pacing is inhibited because the normal beat is there. So A sensed, V sensed. Sinus node is poor, A paced, but the AV conduction is normal, V sensed. Both are poor. Sinus node is slow, AV conduction is slow. So A paced, V paced. And here, A sensed, V paced. That means the sinus node is normal, but it cannot conduct through the AV node. It has to track through the pacing. That's why it is also called, when it is asensing V pacing, it is also called tracking. So these are the 4 different phases of the dual chamber pacing. It could be normal completely. You put the pacing, put the magnet on the pacemaker, they will start firing both. They say, okay, pacemaker is working. About atrial pacing, V sensing, both are slow, AV pacing. A is good, V is not coming up. So A-sensed, V-paced, that is also called tracking. Almost there. So what happens when the magnet is applied over the pacemaker? The pacemaker temporarily switches. If it is a VVI pacemaker, temporarily switches to VOO in the single chamber pacemaker. If it is a DDD pacemaker, it temporarily switches to DOO in the dual chamber devices. And how do we use that, this kind of things? It's checking the pacemaker battery. And there are some pacemaker which tells you when you apply the magnet, the battery is low, what is the rate of the pacemaker? The normal rate is this. When the battery goes down, the rate is different. If there is an EMI, electromagnetic interference is present, patient goes for surgical procedures, they are doing cot rate. It can inhibit the pacemaker. Patient is pacemaker dependent. In that case, we put the magnet and tape the magnet over the pacemaker. It will not be affected by the cauterizations. And then sometimes device troubleshooting. Somebody goes into pacemaker mediated tachycardia, where there is a V pacing, A sensing. You apply the magnet, it paces the A and V now, and the tachycardia breaks. So that's the third use of the. Okay, do we have time for CRT, or should we have some question and answer?
I think, thank you, Dr. Sunil. At this point, we have two moderators with us. Dr. Anupam Bambani, she is a very talented cardiologist, and she is heading Department of Cardiology at AIIMS Patna. So she is there. And Pawan, are you there? Dr. Pawan, are you there? Not. Anand, Dr. Pawan is there somewhere? Okay, I'll welcome Dr. Anupam Bambani and take her comments or few things she wants to give message to the PG students, and some clarification or something from Dr. Sunil.
Yeah,
Over
thank
to
you very much, sir. That was a wonderful talk, and the way you explained how RR interval shortens in Venki back the mechanism, I think that was made very easy, and it is something which is very difficult to understand, and most people don't understand that. But that was with the help of a ladder diagram. It was very clearly explained. Sir, can I ask you something? According to your experience, more often than not, it happens that in inferior wall MI, especially late presenting patients, when we revascularize right coronary arteries, sometimes the intrahesian block persists for long. The QRS continues to be narrow, but they still do have AV dissociation intermittently. So how do you manage? Do you advise pacemaker after a particular duration, or how do you manage these patients?
Good question. So in case of inferior wall MI, that patient may have transient. That transient could be few days, transient AV block. Okay. So in that case, we give patient few days time to recover. Okay. Sometimes if it is too slow, what we do, we put the temporary wire and give the chance patient to recover. And if there is definitely mechanical block because of the infarction and RCA supplies the AV conduction system, then in that case, finally, we consider pacemaker. But definitely for the first few days, we gave chance to recover. If at all, we put the temporary wire and watch a few days.
So is there a particular duration that you wait for?
There
Or
is no specific durations, but usually it may linger 3 to 4 days. I have seen it's lingering. But if the patient has wide QRS, then definitely we think that after 3-4 days, this patient is not going to recover. If the patient is narrow QRS, we still think that there is a chance of recovery.
thank you, sir. So other than that, I think it was very clear, very lucid explanation for all
I tell you
bradyarrhythmias.
one thing which is, I always enjoy talking about Quebec. I was a fellow in New York And my mentor, Dr. Hollander, he used to come for the round every day. And I told him that when I am in the CCU service, Dr. Hollander come late because I enjoy teaching myself to the fellows, to the residents. So he would say, okay, I'll come late half an hour. So one day he came and he started talking about Movies type 1. And I was standing behind and says that, what happens to RR interval? And then he will look at the residents, nobody's answering. Then he turned his head to me. I said, RR interval shortens. And that day, somehow it came on my lips. So why does it shorten, Dr. Jha? I said, because there's a decremental increase in the PR interval. So he loved that word, decremental increase. He was very calm and says, I like this word. I like this word. You said decremental increase. It increases in the decremental fashion. So my message to the PG students will be that remember this word, the PR prolongation is in a decremental increase in the PR prolongation. So that's how the RR interval gets short. And you have to think about it. Just when I explain, it sounds lucid, but it becomes yours when you start thinking yourself and do some math inside that why the RR interval gets shortened, then you will get the answer. That becomes yours then.
Yeah, true, sir. Thank you so much. That I think that decremental increase, that is a term which makes it very, very clear.
Exactly.
And if we
Everybody
remember that, those two words, definitely everybody would remember what is the reason behind shortening, progressively shortening RR interval in Banky-Back. Yeah, thank you so much for giving us those insights.
Thank
I think if students have some questions in the chat box.
we have about 5-10 minutes. I have told my
Dr. Neha has put a question. Is bundle pacing, left bundle branch pacing, or multi-component pacing system in today's scenario? I mean, you can give a brief comment, Dr. Sunil.
That's a very good. Well, so anytime I feel that this patient is going to pace too much in the RV, I do left bundle pacing. I'm the one who puts almost every case left bundle pacing, okay, nowadays. So if the patient has AV conduction disorder and you suspect that this patient will be pacing more than even 20%, it used to be 40% in the RV, then it will cause ventricular desynchrony. The normal heart beats both the sides together. Okay. Two girls under the water, they move the hands in the Olympic Games. That's synchrony. One side, if the conduction system is poor, patient is pacing one side only, so that side will beat first, then the next one beat first. This desynchrony over the period of time leads to pacing-induced cardiomyopathy. Pacing-induced cardiomyopathy. To avoid that, what we do the left bundle branch pacing. So what we do, rather than putting the pacing wire at the right ventricular apex, we go in the septal area, posterior part of the septal area, and then screw the lead into the septum and watch the QRS morphology. If the QRS morphology changes from the inverted W pattern to RS pattern, there are different patterns also, but grossly this is, that means we are capturing the left bundle. There we are capturing the left bundle. That's called physiologic pacing. The benefit is that this patient will not develop pacing-induced cardiomyopathy because you're almost pacing both the sides at the same time because you're capturing the left bundle, so you are pacing the left ventricle, and then you are in the septum. So this is, you don't let the patient have ventricular desynchrony, and it prevents the development of pacing-induced cardiomyopathy. That's how we choose to put the left bundle area pacing. It used to be his pacing, but his is this short structure. It's very difficult to catch his. Sometimes it is encased in the thick tissue. But left bundle branch, it's a big area on the left side of the septum. It's like dropping the helicopter in the small helipad versus big helipad. The helipad is big on the left side. The chance of capturing the lead bundle is much easier as compared to capturing the his. So that's why we do invariably lead bundle pacing. And my practice, if I think that this patient is going to pace more than 20% in the V, I use the lead bundle pacing.
It's a very clear answer and very clear message you have given to everybody, all of us. That left bundle branch pacing, left bundle area pacing, basically.
Right.
And rightly you said that helicopter, landing on a very small spot is very difficult, and copters landing on a very large area
Right.
is easier. So that's fantastic. This we should remember. All students over here, they should remember this: left bundle area pacing or left bundle branch pacing versus his pacing. What is the basic conceptual difference? So, any other question or any other comment, Anupam? You are heading Department of Cardiology, and you have so many PG DM students under you. What is your overall impression about left bundle pacing? Have you
Sir,
started?
we have started, sir, but we are not doing as commonly as you said that if you expect if you anticipate that more than 20% would be pacemaker driven beats, so then you go for left bundle. We don't do so often. One reason is financial constraints also is financial constraint, but other than that, if patient can afford and if he requires pacing for complete heart block, we definitely offer. And one thing in this context, I would like to ask, sir, do you strive to get selective left bundle pacing in every patient, or once you get left bundle area pacing? Uh, because we usually, although we do use EP system for monitoring during the procedure, we usually don't get left bundle potentials. So, or maybe we don't know how to look for them.
Yeah.
How to, yeah,
Lead bundle
left.
potential is hard to get. It's hard to get.
Mm-hmm,
You will not get.
mm-hmm, mm-hmm,
So two things I concentrate. Number one, so what I do, I go RAO, and you have a double curve sheet or C315 sheet for the Medtronic makes it. I will send Jude also now. And then it's easy to cross in RAO. So go RAO, and I use the glide wire and cross. Glide wire goes to the RVOT, and then you cross. When you cross, to get the benefit of the double curve, take everything out, the dilator and the wire out. Then the shape of the sheath itself guides you towards the septum. And I keep counterclock, so that it is in the posterior part of the septum. Anteriorly, it is close to the diagonal artery. So sometimes you can affect the diagonal artery. And posterior part septum. So I tell my assistant that keep holding the sheath counter, keep holding. So I get and then I start screwing the lead. Before I screw the lead, I check unipolar, okay? And then I see the W pattern, okay, W pattern, and then I start going in, watching the impedance, that it should not drop too much. Then you watch impedance. There will be change in impedance, but if there's sudden change, a very sharp drop, that means you might be on the left side, okay? So watch it. So give 3-4 turns again, and then you see that the notch of the W starts shifting distally. It starts shifting distally, and as soon as you capture the left bundle, then you see the small R starts coming in V1. So definitely I tell my staff that if you don't have all these channels, at least have V1 and V5. Why V5? I look for the left ventricular activation time.
yes.
So I go there, I say measure the spike of the pacing to the spike of the QRS, either it is positive or negative. And if that is less than 85 milliseconds, 85, sometimes 90 also, that means you're a good spot. Then I start screwing it, looking at the QRS complexes. Sometimes, well, if you get the lead bundle potential, that's great. Sometimes what happens when you touch the lead bundle, there will be a PVC, but that PVC will be of right bundle branch block pattern. Okay, that means you are on the left side. So these are the few things. So ventricular activation time and the QRS morphology in the V1. Ventricular activation time on the left side, that's V5. These are the two channels I always use for the lead bundle pacing.
Thank you, sir. That was very helpful. But sometimes patients have a baseline right bundle branch block.
Yeah.
So in those cases, how do we monitor the changes in V1 while screwing the
Yeah.
left bundle lead?
Sometimes you look for the QRS narrowing though. QRS narrowing. The QRS narrowing
Okay,
helps.
it becomes
I was doing,
narrower than the baseline.
I was doing the pacing and I never got the tiny R and keep going at one point, but the QRS was 99 milliseconds. I was happy. I stopped there. Okay,
Yeah.
QRS 9, stop there. So that's, the few things, everything doesn't come in the textbook pattern, but there are a few things that satisfies you. And then that's it. Especially if I'm doing the coronary sinus lead and I don't get coronary sinus lead, then I do the bailout. I put the lead bundle lead, lead bundle area pacing and connect to the left ventricular port. In that case, I am more into that. Definitely all these criteria should come up, okay, because then the patient will get benefit. But if the patient has chance of 20% pacing, but at least even if you don't get best QRS what you wanted, but at least the patient will be septal pacing and the chance of development of cardiomyopathy will be less.
Thank you so much, sir. That was those tips will definitely help us for doing more cases. So, sir,
Always helps me. I'm not at this apex, so I'm not too much worried about perforation or although in these cases. So I enjoy doing it. Once you do 4, 5, 6 cases, then it becomes so easy to put lead bundle pacing.
Dr. Pawan, are you there by any chance? Dr. Pawan, are you there by any chance?
Yes, sir. Yes, sir. Good evening, sir.
Yeah.
And
So
it was a very insightful discussion, sir. Just one or couple of questions, sir.
yes, go ahead, please. Go ahead.
Sir, out of if the patient is having a severe LV dysfunction and with the ECG suggestive of LBB and QRS with almost 150 or more than 150 milliseconds. So what do you prefer, sir? Whether LBB area pacing or CRT?
Well, the gold standard as the guideline still says that you have to put the CS lead. So I tried that first, okay? If I'm not happy, suppose the CS branch is not good or the narrowing of the QRS is not good, then I say, well, this patient is not going to benefit it putting the LV lead in the CS, then I do the bailout. But to be honest with you, eventually for the lead bundle pacing at present time, the indication is different. The guideline, it says the class 2B or class 2A or AB, class 2A or B indications. But if the lead bundle branch is there to 150 QRS, class 2 or 3 heart failure, and then you do the CS lead, that is the class 1 indication. So actually I had slides after that, but I didn't have the time. So that's basically, in this case, I will choose this branch. I will not choose this branch. Don't let the lead go anywhere it goes and you are satisfied. You satisfied what you wanted to do in this case. In this case, if you put this one, patient is not going to get. My lead is here in the lateral branch, which is closest to the lateral bottom of the left ventricle, will get benefit. If I don't get this branch, if I don't get good QRS narrowing, I say, well, let's go for the left bundle pacing. Then I do that. So this is how we decide. So this was the indications. Well, for those, this is the algorithm for those who are symptomatic or significant risk of bradycardia. If it is no pacemaker indicated. If it is yes, then look for if it is chronic AF, put the single chamber pacemaker. If other than chronic AF, you put the dual chamber pacemaker. This I made make it simple. So symptomatic or chance of significant risk of bradycardia. So somebody comes in complete heart block. this patient has chance of Stokes-Adams phenomena. He can die of ventricular fibrillation, bradycardia induced. Then I say, hey, you have the chance of, even though you are not symptomatic, so significant risk in there. In that case, I will do the pacemaker. But if the patient is chronic AFib, then decide BVI. If other than chronic AFib, it's a dual chamber pacemaker though. It came in 2011 November. That's the indications for the BIV. Quickly, I'll tell you, if the lead bundle is pattern is there equal to or more than 150 milliseconds QRS, class 2 or 3 heart failure, 35% or less, despite good medications, then that's class 1. All the others are class 2 indications. If ischemic cardiomyopathy, if the EF is less than 30%, equal to or less than, QRS is 150 or more, ischemic cardiomyopathy, then in that case, class 1 symptoms, also you can do the BIV, but that's class 2B indications though. If patient is ambulatory and class 4, where they can benefit with the BIV, but then you can do BIV ICD in those cases. But if there is not ambulatory and the patient is refractory symptoms or dependence or intravenous inotropes, don't do it, okay? Device is not indicated. Device is already in place, sometimes you have to deactivate the defibrillator. So that's how this goes. So answer to your question, yes, I try the coronary sinus first. If I don't get the good, it doesn't satisfy me, I do the bailout.
Sir, just regarding this question only, sir, if you prefer to do, whether you prefer to do CRTP or CRTD, or you have sir, whether there is indication of cardiac MRI to look for the scar, the patient is having the severe LV dysfunction, sir, 30%, coronary angiogram normal. So these are the non-ischemic cardiomyopathy with LBB and QRS width of 150 milliseconds. Whether you do cardiac MRI to look for the scar, or whether to go straightway for the CRTD, sir.
Well, Pavanji, cardiac MRI is not that financially, possible in every case. Ideally, you're talking about the research part. Yes, if you look for the scar, I basically look for the echocardiogram, the area of poor, the regional wall motion abnormality. Okay. If the regional wall motion abnormality is big, I try to avoid that area. But you know that BIV is not always possible what you want to do. Okay, the anatomy is such, then you take a chance. No, I don't do MRI in every case. I don't think anybody in US also, where things are done so promptly and easily, but I don't think anybody, unless you do some research, they do MRI in every case, no.
What about the LV dysfunction, severe LV dysfunction, dilated cardiomyopathy? Do you recommend doing MRI also to look for scar or some secondary causes?
Yes,
things like
like suppose somebody comes and has history of sarcoid, okay, and history of sarcoid, then we look for and that any scar is there that can be a source of ventricular tachycardia, or like a
Dr. Pawan, I'll ask you how many cases we have done in Medanta left bundle pacing, and what was the result? Just quick review so that Dr. Sunil can comment on that, because we have taken a lot of time.
I have 2 more minutes. I have to go.
Yeah. So, Dr. Pawan.
Yes, sir. Actually, most of the cases we have sir performed around 100 to 110 cases of LBB area pacing, and most of these cases were with the LBB with the QRS width of around 140 or more than 1. And sir, we had found the good results, but we could not achieve the proper. In many cases, we could do the LV posterior. We have captured the most of posterior fascicle. So there was, sir, I want one query also. If we capture the left posterior fascicle, and we identify it there by getting the Q waves or in 2-3 AVF or a small R or a large case in the 2-3 AVF. So these whether these patients benefit from LBB area pacing?
Well, they should
Because
benefit even if you are lower down. Even if you are lower down, they should benefit if you have a good capture of the lead bundle. But every case doesn't improve. Every case doesn't improve if they have a lot of scars and all those. But lead bundle pacing helps you preventing the worsening of the LVEF, definitely.
yes, sir.
As-
Yes, sir.
But every
Actually, we have
patient,
also seen that, sir, if the patient is having EF of 30 to 35%, and we have done the LBB area pacing, at least the patient heart failure symptoms doesn't deteriorate; it improves. Second,
Right.
there is no deterioration in the LV functions.
So
At least
that
it stays there.
exactly. So, even if you capture the posterior fascicles lower down, but these patients, if they are improved, that's fine. Even if they don't improve, at least they are not worsening so far the heart failure symptoms are concerned, though, as opposed to RV apical pacing.
Yes, sir.
Okay, should we? Yes.
So
Any more?
let's thank Dr. Sunil Jha for the
Thank you
excellent
very much, sir.
deliberation.
That was
Thank you, sir.
really,
Thank
really
you, sir.
excellent.
Yeah.
We expect him to come to our place.
When
This
I come
time,
there, I tell you,
Anupam
Sir,
grand
Bambani will
rounds are
take
not
the
easy.
onus of
Grand
Sir,
rounds,
we'll really
getting
look forward to it.
Yes.
grand
We will
rounds
look forward to
for
it, sir.
learning. Okay,
So,
give me time,
and
and then it should be interactive sessions. That's the learning. Grand rounds are very lucrative. You hear this, okay, but learning part for the postgraduate students or DM students is when you are interactive.
I'll request him to uh, uh, make grand round available to us also. The
yes,
Patna
please do, sir.
cardiologists. I've
Please
been
do, sir.
requesting him, and
I'll
I'm
tell
sure
you,
that
those
this will be possible.
yeah, we do the grand rounds here every month, and well, when I am definitely in India, I come to Patna. I will definitely visit you.
Yeah.
And
Sir,
Panji,
whenever you intend to come next, please do come to AIMS. We would
I
definitely
will come there, and then it should be like a long interactive sessions that
definitely, sir.
that really helps the PG students, though.
Yes,
That's what
sir.
And
Yes,
but
sir.
if anybody wants to join our grand rounds, I'm in charge for electrophysiology here. I do the rounds myself, or I invite the international speakers of big guys once in every month. And if you want, I can send you. Ajay ji has joined a couple of them. If you want, I can send you the link, and you are most welcome. They can, if any MD students or especially DM students, if they want to join, they can join us.
So we
But
would love
time
to do
will
that.
be-
Please do share the link. Definitely, we'll join in.
Yeah. So send me your email, Dr. Anupam, also.
Sure, sir.
And
I will do that. I will
Dr.
do that.
Mohanji,
Ajay gets the link
you
very
can
often.
you can snatch some more skills from Dr. Sunil by
Yes,
getting
sir.
into grand
Yes,
round.
sir. Sir is a
Yeah.
very, he's a great teacher, sir, and it's a very pleasure to listen him, sir. Actually,
Yes.
Sir,
True.
can I have your email ID, sir?
Yeah. You can write it down. S-Jha1, S-Jha, J-H-A.
Anupam, I'll send you.
Yes,
The
sir.
one.
Right now, I'll send you. Don't worry. I'll send you his details with his
Okay.
mobile number
At
and
uthsc.edu.
email address.
uthsc.edu.
He's already selected. Now you'll be professor of University of Tennessee.
2 days.
Yeah. So that's a great
Great,
honor
sir.
for all of
Congratulations.
us.
Congratulations, sir. It's
Well,
well
I cannot
deserved.
say officially,
So much, sir.
but it's not decided by the chancellor. So it goes to the UT system where they vote, and then from July 1st, hopefully, finger crossed.
Great, sir. Hearty congratulations.
Thank you. So
Thank you
congratulations,
very
sir.
much.
Yes, sir.
S-Jha1 at uthsc.edu, uthealthscienceCenter.edu,
I'll
Noted,
send
sir.
her right now. Don't worry,
Yes.
sir.
I will pass it on to Ajay-ji and then he will share with you. Okay.
Yes, 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 sir. Thank you for giving so much of time.
Yeah, send me Anupamji's email, then
Sir,
I will.
I'll drop a mail immediately to you.
Thank you so much. And it's
Thank
so
you
good.
so much, sir. Pleasure is all
Thank you.
To all the
ours.
students and
Thank
all
you.
our
Thank you.
moderators
Yes,
for
most
giving their
likely,
expert comment and making
my
the
daughter,
program.
my daughter is getting married next year, so she's engaged. So hopefully I'll be coming to Patna for shopping. Then I will definitely stop by and share my passion of cardiac electrophysiology with you guys again.
Thank you, sir.
It's pleasure, sir.
Okay, thank you.
Thank you, bye. Thank you
you.
very much. Thank you
Bye.
all.
Bye.
Thank you, Anupam. Thank you, Pawan.
Sir,
Thank you,
thanks
sir.
for
Thank you.
involving me.
Thank you. Yes.
Bye-bye.
Bye-bye,
Bye, sir.
Sunil. Bye.
Bye-bye.